Okay, everyone, welcome and thank you for joining us today. We do have a poll that we're launching as you're joining the meeting. So I see some responses coming in. Thank you. Please feel free to respond. Also in the chat, if you'd like to this, if you can't participate in the poll itself. We are here today to bring you the Medicare Hospice Program Integrity webinar, and Jennifer Kennedy and Kim Skehan will be describing to you what this means for providers in the industry. If you have questions throughout the presentation, please use the Q&A. If we have time at the end, we'll address some of those questions. If not, we can run that as a report and publish an FAQ after the fact. And with that, I'm going to go ahead and turn it over to Kim and Jennifer.
Great. Thank you so much, Denise. This is Jennifer, and I'm really happy to be with you today. Kim and I have a lot of material to cover, so without further ado, we will go ahead and get going. Kim, it looks like I can't move slides, so if you go ahead and move for me. There we go. Thank you. So let's go right to the first one, if we could. Perfect. So in order for us to really talk fully and intelligibly with you today, we have to give you an idea of what the hospice environment looks like. We are at an unprecedented time in the history of hospice in the United States, where hospice is under the highest scrutiny. And there have been many factors that have pushed that forward. There's been very much hospice in the media and media coverage of hospice in some of the poor performance organizations and experiences that consumers have had over time. So that has thrown hospice into the spotlight. And we know that there's more oversight, there's more regulation, more scrutiny from various federal entities, and operating a hospice is more challenging. You're having staffing issues, we have a short length of stay issue, there are audits, and as I mentioned, increasing federal regulation. So how did we get here? I think the immediate thrust of hospice into the spotlight really broke open in 2019 when 2 OIG reports were posted. As you can see here, I listed the reports with the links so that you can get to them easily. The reports really put a focus on the survey process and the OIG's perceived lack of CMS's oversight of that process. And the other report was reports of 12 cases of harm specific to individual hospice cases and where they received very poor care. So based on these reports, there were calls from legislators and stakeholders for stronger oversight on hospice. And hospice had been on the scrutiny forefront for several years because of the fact that it's grown very significantly since 2000. There have been increased mergers, acquisitions, and the like of Medicare certified providers. And we have the entry of private equity. At least 72% of hospices acquired by private equity were nonprofits, and that trend has really ratcheted up into 2022 and beyond. Next slide. Great, thank you. So I mentioned hospice growth. I'm not going to spend a lot of time on these data slides. They're really more for your benefit. But the point here is that there has been significant growth in hospice since actually 2020. And much of that growth has taken place in key states like California and Texas, but we've seen some other states jump into that bucket, Nevada, Arizona, and there are a few other states that CMS has been watching because they're showing slight uptick of growth in hospice providers. So for-profit hospices are up about 10%, freestanding hospices increased about 9%, and 86% of hospices were in urban areas as opposed to rural, where we really have a need of provider concentration in rural areas as well. Next slide.
Do you see it, Jennifer?
Yeah, so we're at life discharges.
Okay. Yeah.
So
yep.
It's important to know and for you to watch that your live discharge rate, because for sure the federal government is watching your live discharge rate. The last report we have of the national live discharge rate, which was sitting at about 17%, was in 2021. So we're going to be due for another data dump coming up. I would expect absolutely we'll see new data with the MedPAC report that comes out this coming March. And then we may see a data dump from CMS in the proposed rulemaking in this spring. So the point here is that CMS is watching not only the percentage at a national rate, but at your rate as well of live discharges, and particularly the reasons that you as a hospice are discharging your patients, or what the national trend of reasons are over time. Next slide. So non-hospice spending, this has been an issue that's been going on for maybe about 5+ years. And CMS has really been watching as hospice growth has been blossoming. They're watching the spend that's happening in other parts of Medicare outside of that benefit. So parts A and B and D particularly. The last data we have is from 2022, where you can see in parts A and B, 472 million outside of the benefit for physician services, 100 million for outpatient services, 145 million for inpatient services. And when we look at the D spend, it's about 623 million. So when you look at hospice beneficiaries who are under the Medicare hospice benefit, there was a spend of about 197 million between part A and B in terms of the cost sharing for that patient on the benefit. And in Part D, about 68 million in cost sharing for Part D drugs while in hospice. So what is the message here? They're watching, many entities, even outside of CMS, are watching this spend outside of the Medicare hospice benefit. And that is something that you need to be watching as well. If you're responsible for the cost of that care, you need to own it. You need to pay for it. You need to be responsible for it. It's when we're getting into these millions of dollars outside of the benefit is when there's more chance that CMS is going to make regulations that will change how we're paid, what is covered, etc. Next slide. So I wanted to talk a little bit about, as part of how we got here, is the lead up of media, the spend outside of the benefit, live discharges going up, growth going up, which has really led to, in part, fraud and abuse that is happening in hospice. And that's really what has pushed hospice to the forefront of scrutiny on all fronts. There's been an increase of newly certified hospices, particularly in those target states I mentioned before, California, Texas, Nevada, and Arizona, over the last few years. And there have been reports of hospices in these states of operating unethical and using illegal practices in their organization. And some of these providers are really establishing their business, to get their Medicare provider number, and then they sell their hospice off or their license off for a profit. California has been the only state to really take action on hospice fraud, and hopefully this is going to push other states to follow suit. In California, there's a current moratorium on hospice licensing, except if there's a demonstrated need for that provider to open and operate a hospice. And there have been two major reform laws passed that also mandate an extensive audit of state licensing and oversight processes. So California has really taken the bull by the horns on this particular issue. Next slide. And there are many scams that have been reported out here that are have happened, are happening. We've seen the report in ProPublica about 2 years ago where multiple hospices were operating out of the same address without a corresponding increase in a need or the population of eligible patients in that particular service area. Admitting patients without their knowledge, referral kickbacks, admitting ineligible patients for hospice care, moving patients between states to serve as patients in hospice startups, fraudulent hospice physician billing, even using recruiters who call individuals to sell hospice and to get them to sign on to hospice, even if they're not even eligible for it. So these scams have been targeting older congregate settings, such as going to bingo outings and assisted living care facilities, and trying to sell hospice and get individuals to sign on to their benefits so that that organization can start billing. Next slide. It's even come to this point where I've been providing hospice care in my career for over 25 years, close to 30 years, and I never thought that I would see a notice like this from the federal government. And this came out a couple of months ago, which was in response to some of those scams I just mentioned, and targeted for Medicare beneficiary aged people, to tell them that they need to be aware of scammers offering older Americans in-home perks, money, cooking lessons, cleaning, transportation in exchange for being signed up for hospice services. So this is an active thing that is floating out there on Facebook and X and Medicare.gov to really help individuals know about these types of scams that are happening. All right, and just to sort of round this whole fraud and abuse and scam issue out, there is action happening at the federal level, and people are being held accountable and prosecuted. For example, here, the CEO of a hospice in Dallas texted members urging them to administer drugs to patients to avoid exceeding per payment spending gaps. So he urged them to hurry the patient's death along with drugs. And he sent them texts praising them when these patients died from drugs, and things like good job on that case. There were also accusations in this particular case of recruiting patients who weren't eligible for hospice and falsifying their documentation. So you can see what the taste of the outcomes here are. We have individuals that actually pled guilty, individuals that were sentenced to a combined 84 years in prison. So you see that with proper outing of this behavior and reporting of this behavior, consequences do happen at the federal level for these individuals. Are we stuck, Kim?
It's not showing. It should say program integrity. It's not showing.
Yep, it's showing now. So thanks so much. So at this point, after doing a quick setup of the landscape, I'm going to turn the baton over to Kim, who's going to talk to you about enter hospice program integrity as a result of some of these items.
Thanks so much, Jennifer, and hello, everyone. Jennifer and I, as you know, are longtime colleagues and friends and hospice nurses in the industry, and we welcome all of you today to this important topic. As Jennifer said, all of these years of hospice growth and has led to the scrutiny from the federal government, by the federal government, and the findings and the observations and reports that Jennifer has laid out. As a result of the reports and those findings, CMS has implemented hospice program integrity efforts throughout the nation, with a focus on the target states, but they do impact all states as well. And it does encompass both survey as well as payment audits. So it's important to understand, you know, the implications from a payment perspective as well, and documentation related to payment, as well as survey and regulatory. So in July of 2023, CMS placed newly enrolled hospices located in the target states of Arizona, California, Nevada, and Texas in a provisional period of enhanced oversight, or PPEO, related to numerous reports of fraud, waste, and abuse. This included prepayment audits on 100% of hospices undergoing initial certification. As of September of 2024, CMS expanded this prepayment review to include both new and existing hospices. And although there is a focus on the target states, there are other states that may be factored into this prepayment audit as initials if they meet, or existing hospices if they meet certain criteria. So understanding that these audits, these PPEO audits, are in addition to any other government audits that may also be implemented, such as TPE or SMRC, for example. With the survey refocus, related to those reports, there were some changes, major changes in the survey process that really began with the passage of the Consolidated Appropriations Act of 2021. And this includes enhanced or more specific surveyor education and reporting of conflict of interest. Accreditation organizations now submit hospice survey findings electronically to CMS. There also was the implementation of intermediate sanctions and enforcement remedies that we'll review briefly. And then Jennifer will review the key points of the special focus program. In addition, there was the implementation of a withhold increase of 4% for hospices that fail to meet timely submission requirements for hospice quality reporting related to HIS submission, soon to be HOPE, as of October 1st of 25, and also failure to participate in or file an exemption for hospice CAPs. So this was all part of that, this Consolidated Appropriations Act, and we'll go over briefly some of those changes. With the changes with survey process, CMS does require, although this has been long-term, but they did specify it in their instruction, that all state survey agency surveyors and accreditation organization surveyors are required to take CMS surveyor basic training, as well as additional training specified by CMS. If you have an IPU, an inpatient unit, you will find that those surveyors who conduct life safety code surveys must complete additional training in addition to the hospice basic training as well. And all surveyors must complete this training just to ensure that they can conduct accurate and complete surveys. CMS also has implemented direct observation validation visits, or DOVs, with an AO. to evaluate the AO survey process and outcomes. This Dove survey process was implemented in October of 2023 and replaces what many of you may be familiar with as the prior validation surveys, where CMS or the state surveyor would follow the AO surveyor and conduct a separate survey, which often resulted in different findings, 2 plans of correction, and potentially additional condition level deficiencies, right? Or condition level deficiencies that weren't cited initially. CMS did work on a pilot for the Doves and implemented in October 2023, continuing on now into the CMS fiscal year 2025, 2024 and 2025. So we're continuing on where these CMS contractors arrive with the AO surveyor and observe the AO surveyor during the survey. They do not participate or conduct any aspect of the survey. They observe the survey process. So as well as it may be stressful for an agency to have CMS or a CMS contractor present in addition to the surveyor, please understand that this process is observing the AO, not the agency, not your agency. So we actually have found at CHAP that this to be a very collaborative and beneficial approach. So we will, right now, Dove surveys are completed on renewals or recertifications, but there is a potential plan for these Dove surveys to also include initial certifications in the future. I won't spend a lot of time on this next slide. Appendix M was updated in January of 2023. Again, this was as a result of the Consolidated Appropriations Act and the changes in focus to ensure that the surveyors focus on the quality of care provided to hospice patients. There are new and refocused tasks in the survey protocols. Many of you may already have had a survey using the updated Appendix M guidance and standards. If you have not, I strongly encourage that you review them. But even if you have, utilize Appendix M, especially the introductory sections and the information gathering sections and clinical, sampling, all of the sample recommendations for home visits, interviews, document review, and clinical record review. You want to ensure that you utilize this valuable resource to be able to enhance and implement your own ongoing survey readiness process. Again, there are 4 core hospice COPs that emphasize the assessment of quality care in a 2-phase survey approach. Phase 1 focuses on those aspects of the standards and conditions that relate to direct patient care. So really focusing on clinical record documentation, patient interviews, home visits, and observation. And they encompass patient rights, initial and comprehensive assessment of the patient, and interdisciplinary group care planning and coordination of care. There are 6 associated COPs with phase 1. The intent of CMS in the survey process is that phase 1 will inform phase 2, which includes the 1 COP related to quality assessment and performance improvement, but there also are 13 associated COPs under this particular phase. And the objective is, or the intent is, that the phase 1 findings will inform the surveyor of any potential systemic findings that may be found in phase 2. But it is important to note that all COPs are weighted equally. In November of 2024, CMS did release a memo to the survey agencies and AOs to ensure consistency in the hospice survey process to identify quality of care concerns and potential fraud referrals. And this is important because it is very clear in this memo that CMS is saying that while the primary purpose of surveys is to determine compliance with the Medicare Hospice COPs, there are several elements of the survey process that can uncover concerns that would necessitate a referral to CMS for potential fraud. As part of this memo, the CMS states that the SA and the AO surveyors are required to maintain adequate documentation that includes patient lists, as an example, to support findings of noncompliance that are reported on the CMS 2567. Also, if evidence or concern of potential fraud is identified during a survey, a referral should be made to CMS by the state agency or the AO through the appropriate reporting channels. In addition, CMS highlights these 4 areas that are listed in the appendix M, but serve as reminders to surveyors to make sure that they are focusing on these areas when looking at both in survey compliance with the COPs, but also, again, the potential for fraud and abuse. And this includes observations, which includes home visits, interdisciplinary group participation, if the IDG occurs during the time of the survey, reviewing or surveying multiple locations, ADS locations, especially if one has been added since the last survey, or if you have an IPU. Also, the ability for your hospice to be able to provide care, all 4 levels of care. So, and ensuring that the documentation supports that if the patient needs is determined that the patient could benefit from or should have be served in a higher level of care, that care is provided. Also, access to care, including after hours and weekends. And in interviews, the key here is just a reminder that surveyors must check for availability of translation services. That means your hospice's ability to be able to provide them when when needed for patient communication. And then record reviews include clinical record reviews, but also your complaints, your complaint process. Remember that substantiated complaints is also one of the SFP algorithm items. And then hospice administrative oversight, and CMS outlines several areas here that are important. One that I do want to point out is CMS hospice forms, the accuracy of your 855A, any changes, any change, and the 643 and 417 that are also sent as part of the survey. And you want to make sure that those documents are accurate and align with your current address, administrator, etc., board, what the requirements are, and also make sure that your state licensing documentations align as well. CMS is looking at them very, very closely. This is this next slide is our top 10 hospice deficiencies for 2024 for CHAP. They are overall in line with the top 10 CMS priorities in terms of top deficiencies. If you want to see this or obtain a copy of these findings, you may scan the QR code that's in your handout to be able to access this information on our website. I just want to point out that, one of the common areas or 2 common areas are related to plan of care and individualization of the plan of care, completion, and that interventions and treatments are provided or in accordance with the plan of care, assessment, comprehensive assessment timing, and drug regimen review. And I have to take a moment to say, Jennifer and I have been in hospice for decades, and we really would love to not see hospice aides in the top 10, and yet every year we do see this. So as an organization, if you could look at your hospice aid compliance, ensuring that you have hospice aid care plans present, updated, aides are following the care plan, and they are reporting any changes in the patient's condition. Also, making sure that supervisions are timely. We would greatly appreciate that. I put the slide in for immediate jeopardy because, and I won't go through a lot of the detail, but just understand that condition level deficiencies and immediate jeopardy are considerations when CMS is looking at enforcement, implementing enforcement remedies as well as SFP. And immediate jeopardy, the key here is that it can happen easier than an organization can think. If you do not, you really need to make sure that you have a strong concurrent review process. Remember that only one individual needs to be at risk. Harm does not need to occur before considering immediate jeopardy, and consider both potential and actual harm when that's what the surveyor needs to review. There are 3 requirements: non-compliance with a standard that caused or created a likelihood that creates serious injury, harm, impairment, or death to a recipient would occur or recur, and that immediate action is necessary. And it is in the need for immediate action that determines the difference between a condition level deficiency and immediate jeopardy. Most often, that's the 3rd criteria. Most often, immediate jeopardy occurs as related to patient care. So you want to make sure that your clinical documentation, your home visit observation, your care is demonstrating optimal health and safety and compliance with regulations. Just briefly, enforcement remedies, again, have been implemented as part of the Consolidated Appropriations Act. And just a reminder here that all remedies imposed would apply to your parent hospice and your respective multiple locations under the CCN, and that deficiencies found at any location under the parent CCN are applicable to the entire hospice agency. This next slide, I have outlined the hospice survey enforcement remedies. They are listed here on the left. And the one that I would point out is civil monetary penalties, which can be imposed up to $10,000 a day or instance. But any of these, any combination of these enforcement remedies can be imposed by CMS or the state agency. And it really depends on the extent to which the deficiency poses immediate jeopardy, the nature, incidence, manner, and degree and duration of the deficiencies, and the presence of repeated condition level deficiencies, and the hospice's compliance history. And CMS does look very closely at the survey findings. We do receive feedback whenever there is a question about findings. So know that CMS and the state agencies are looking very closely at these findings as well. With that, I'm going to turn it over to Jennifer for the Special Focus Program.
Thanks so much, Kim. So this is the latest major highlight that we have seen come out from CMS as it relates to program integrity. And on this title slide, there is a link to a CHAP resource, which is our particular special focus program fact sheet. It's very detailed. It gives you everything that you need to know about the special focus program. And that is just one piece of our hospice program compendium that we put up on the webpage for you to make sure that you have all the details that you need to be informed. So let's talk about what has happened very recently with the special focus program. We were expecting with the refresh of the quality measures in November for CMS to make the selection of the 50 hospices that would be participants in the first run of the hospice special focus program, and that was due to start on January 1, 2025. So what we saw on 2020 was that CMS did post the list of the initial cohort of 50 hospices that were selected, and they were selected because CMS applied the SFP algorithm to hospices, all hospices, and these 50 sifted out as meeting the criteria for SFP and then being placed into the SFP as of January 1. They also generated another list of future SFP candidates, but they didn't publish that one at this particular time. No telling if they will publish it or when they will publish it, or even if they'll hold it until we get to this time at the end of 2025, where again, the November refresh will generate another cohort of hospices for SFP. The reason that the algorithm is applied for the November refresh is that one of the criteria for SFP is the hospice care index measure, and that is a claims-based measure. Claims-based measures are only updated annually, and November is the time when that measure is updated. So you can see here, we've given you the link not only to the SFP cohort, this is actually on the CMS SFP webpage, but also the underlying data that they use to make the selections. So the substantiated complaints and the condition level deficiency list as well. Next slide, please. All right, so I want you to go to our resource that I showed on the title slide. I'm going to go very quickly through the special focus program nuts and bolts, but everything that you need to know is in that detailed resource. We know that CMS has been working on putting the SFP together for a couple of years. The main goal here was to identify poor performers based on a set of quality indicators and other criteria that would be applied to hospices across the board that would sift out the bottom poor performers. The algorithm combines several indicators that CMS has selected as being part of this algorithm. When a hospice is selected to participate, they're going to be in that that cycle of SFP for a minimum of 18 months. They will have at least two surveys in that period where they have to have no condition level deficiencies, or there could be no substantiated complaints in that time frame as well. If for some reason they don't make it through SFP, then they will be terminated be terminated from being allowed to participate in Medicare. If a hospice has deemed status with an AO at the time they are selected for the SFP participation, they are placed back under the oversight authority of CMS and the state agency until they complete the SFP, or they may be terminated from the Medicare participation. Next slide. So it's important to know how you might fit into the selection process. CMS, as I mentioned, will apply the algorithm at the last quarter of each calendar year. If you've billed at least one claim to Medicare in the last 12 months, you're in. If you have data for at least one algorithm indicator, you're in. And if you're operating a hospice in the United States or territories, you're in for selection. Then the fifth, when CMS goes through their algorithm process, it will sift out the participants for the next cohort. Next slide, Kim. What are the algorithm indicators? I'm going to go through those, and then we're going to talk about some of the hot news on I guess the wire about what is happening with SFP, and I can get to that just after we go over the indicators. CMS has selected that survey reports with condition level deficiencies that are in 11 selected quality of care COPs would be one criteria met for the algorithm. And this is a rolling 3-year consecutive data look that they're doing. So they're looking for this cohort. They look back over the previous 3 years at survey reports for condition level deficiencies in any of these 11 quality of care COPs. Again, a 3-year rolling look back at the total number of substantiated complaints received against the hospice. Next slide, please. Another indicator is looking at the hospice care index score. This one you're supposed to, with your measure, aspire to a perfect 10, as we do in the Olympics. But if a provider is not reaching expected national levels in terms of the measure outcome, that could be a criteria to get the provider into the program. And then looking at adjusted bottom box scores of 4 particular CAPS measures, help with pain and symptoms, getting timely help, willingness to recommend this hospice, and overall rating of the hospice. Next slide. There are some exclusions. If there was less than 8 quarters of data for the HCI score or less than 20 claims over that 8 quarters, that would be an exclusion. In terms of CAPS, bottom box scores, if there were fewer than 50 survey eligible patients and caregivers, there would be exclusions, fewer than 30 completed surveys during the reporting period, or new hospices receiving their CCN after a 1-to-1 collection year. So that would be our exclusions for participation in this program. CMS does plan to keep reporting the outcomes of the applied algorithm for SFP selection in the public reporting realm. They plan to continue to publish a list of eligible candidates or who's been selected. And on that SFP webpage, they will eventually show the progress of hospices in that program, who's been completed and who's been terminated. And as I mentioned, it's an 18-month stint that a hospice will spend in the program, and they need to serve 2 surveys with no condition level deficiencies, no substantiated complaints in that time frame of 18 months. If they come out and they graduate, they can come back to an AO or stay with the state. If they don't make it through the program, then they will be terminated. So the update I want to give you is that all through this process of developing the SFP program and the algorithm, particularly the algorithm, there has been pushback on the national level from national trade organizations such as at the time it was NHPCO and NOC separately, and now they are the Alliance for Care at Home, plus Leading Age, the coalition with which many of those organizations are part of, have all pushed back on that algorithm, citing clear evidence of the flaws that comprise this algorithm. The latest that you could read about the pushback was that these organizations organized to send communication to Congress and ask Congress to have CMS stop the SFP from going forth. And this was right around November. And CMS chose not to take any kind of communication from Congress. They went ahead and they moved forward with selecting their first cohort and getting that program going. So this is not the end of it, because these organizations are going to continue to push back. They're going to continue to push the envelope that the algorithm is not fair. It has several integrity flaws in it that would cause organizations that are not necessarily poor performance being looped in and being identified as such, and then having to go through the SFP. So stay tuned. More to come on what is happening on that front. Kim, do you have anything to add on that?
No, I think that that's a great summary. I do applaud the nationals and the state associations for their advocacy. And the other component here is at the moment, plan for CMS to publicly report the bottom 10%, which again, that's the intent of CMS to publish that list. The national associations have asked for this to be, and the industry has asked for this not to be published, which would comprise, I think, around an additional 600 hospices roughly. So it remains to be seen what the plan will be with CMS, given the fact that it does appear as though there are inaccuracies in the algorithm and the data.
Exactly. Thank you so much, Kim. I want to just mention in the next couple of minutes a couple of other program integrity actions that CMS has undertaken in the last year. There have been ramped up payment audits of all kinds of varieties, and those are targeted against improper payment or ferreting out any kind of fraud, abuse, or waste. So you, as providers, have probably seen that you've had increases in audits such as TPE or even maybe ADRs. We know that there are SMRC audits happening out there, as well as RAC audits. That has been something that hasn't been around the block for a little bit. Of course, you have UPIC audits that are happening for targeted providers, as well as continued scrutiny and work from the Office of the Inspector General. There have been some enrollment changes that were effective on January 1st, 2024. So we're a year into this, where we see that CMS has expanded the 36-month rule on the change of ownership to hospice agencies, requiring hospice administrators and medical directors to disclose as managing employees, categorizing hospices in that high-risk provider category for Medicare screening purposes as it relates to ownership, expansion of the reapplication bar from 5 years to 10 years, and shortening the Medicare billing deactivation period from 12 months to 6 months. I know you all had struggled, mid-year last year with the certifying hospice physician requirement. That was effective on June 3rd, 2024, where your physicians had to opt in or out for prerequisite for payment for hospice period in PCOS. So CMS believed that was one thing that they could do to clamp down on program integrity and help to squelch some of that falsifying and certifying types of activity that maybe still are happening out in hospices. And finally, I want to mention quickly that last year the informal dispute resolution process was made a requirement, not only for state agencies, but for AOs as well. So hospices do have the option to request an informal opportunity to dispute condition level survey deficiencies if they don't agree with it. It has to be in writing, either to the state agency or the AO, and they have to outline their argument against why it should be lifted. And they have a specific 10 calendar day period for submitting not only the applicable plan of correction, but also their dispute if they are disputing that. And I'll give you the link there. It's now incorporated into the SOM Chapter 10, where you can read up more on that. So Kim, why don't you bring us home with some program integrity legislation that's up on the table?
Sure. And feel free to tag in. Just this past year, Representative Earl Blumenauer recently introduced the Hospice Care Accountability Reform and Enforcement Act, or Hospice Care Act, to address several long overdue reforms to crack down on fraud while incentivizing high quality care. This has not been finalized. We're still in proposal with the advent of the election year and now a change in administration and a new Congress. and Senate. It remains to be seen what this will look like going into this next year. But the idea is to implement payment reform and bolster program integrity. And these are just some brief examples, again, of this legislation that, again, has not been finalized. One of the largest, the biggest areas that points that were indicated in this proposal was a nationwide moratorium for new hospices for enrolling in Medicare, unless there were exceptions for circumstances where access to care is needed. And that was a 5-year national moratorium, as well as increased transparency of hospice ownership and managing control in information and ensuring CMS's records are up to date, extension of oversight of newly enrolled hospice programs, that's the PPEO that we discussed, and increasing survey frequency for new hospices to ensure they meet hospice health and safety standards. So, and if you're certified, instead of every 3 years, it would be every 18 months for those targeted providers, and prohibit payments to hospices that do not submit required quality data, again, with appropriate exceptions. Then you can see here, and I won't go through each slide, but it's in your handouts, but you can see the information that's required in terms of completion of face-to-face, the election statement, and making sure that patients receive, more information, and revising the payment structure for routine home care, and increasing payments to hospices for furnishing palliative care treatment. And then again, these are some additional coverages that are removing coverages for hospice, home health aid and homemaker services for patients residing in a skilled nursing facility or nursing facility, adds home respite care to the hospice benefit, and creates a new transitional inpatient respite benefit. So you can see that there are some potentially positive changes, policy changes, but there also are some broad sweeping changes or restrictions that would impact hospices, all hospices. So as we wrap up, just some final recommendations and reminders as we talk about implementation and of your compliance, regulatory, and quality functions. You want to make sure that you have your corporate compliance program, that's your billing, addressing your payment audits, and eligibility, documentation to support eligibility, regulatory compliance or survey readiness, and incorporating this also with your QAPI program. It's important to understand that these 3 functions overlap and they're complementary, but they are not interchangeable. An example is when we survey our agencies on our compliance standards, there are times when hospices believe that their QAPI program meets the requirements or the guidance in the 7 elements for corporate compliance, which is again related to payment, predominantly payment, billing, eligibility, documentation, not survey or hospice quality reporting. So you do want to make sure that you incorporate all of these aspects into your programs, and that you have adequate oversight. Develop and nurture a culture of compliance. It needs to be weaved into everyday practice and is the collective responsibility of all teams to uphold compliance standards. Make sure that all staff, management, leadership, and board understand their role and are accountable to their responsibilities and for compliance, as well as regulatory and survey readiness and quality. And the OIG does offer practical tips to foster this culture, and you'll see this information in the resources I will provide in the next slide. But I think the most important bullet here is, just because your competitor is doing something doesn't mean you can or should. So that's an important reminder to all providers. And again, CMS is looking for providers as well as surveyors and the public at large to report any potential fraud and abuse. You want to make sure for compliance that you are establishing a formal compliance program with the 7 elements set forth by the OIG guidelines. Hospice's guidance was developed in 1999 and is still relevant. There is, however, an OIG modernization initiative that where they will be updating all of the guidance. But until that time, there is the 1999 guidance for hospice, as well as the General Compliance Program guidance, which was published in November of 2023. And it really provides relevant and updated examples and information as you implement your compliance program. Just briefly here, these are the OIG 7 elements that are listed in the OIG guidance on the left, and you can see that our CHAP compliance standards mirror our standards mirror the OIG 7 elements, or they follow the 7 elements. We committed at CHAP to develop compliance program standards for all of our service lines, believing that a proactive approach and a reasonable approach to implementing a compliance program, especially in this environment, is necessary for organizations to be able to really demonstrate optimal and regulatory and payment compliance in their care, services, documentation, policies, and operations. Just again, finally, just always take the compliance high road. Make sure that you have that effective compliance program in place using all data to identify gaps in compliance. And again, report suspicious behavior when you see it, whether it's internal to your corporate compliance program or external. And don't forget QAPI and continuous quality improvement. Compliance and quality are hand in hand. You want to make sure that your compliance and quality teams are working together regarding monitoring, response, and sustainability of outcomes. Make sure that your staff receives regular updates regarding QAPI activities, that they know and understand your quality measures and are active in your organization's activities. We have, as part of the survey process guidance, we as surveyors are asked to inquire or interview staff and look for evidence that all staff understand their role in quality and understand what the agency's QAPI program is and the individual's knowledge and active involvement in the QAPI program. Just final recommendations. If you make sure you have an annual compliance program, audit plan, and compliance effectiveness and risk assessment. There are resources, OIG resources that can assist you with this. Again, making sure that you have staff and managers understand their role in ensuring health and safety of patients, survey readiness and response, that they are knowledgeable and competent in clinical practice and consistent in assessment and care planning processes and clinical documentation. And make sure that staff receive education, ongoing orientation and ongoing, not just for the COPs, but for conditions of payment. Conduct mock surveys at least annually using those current CMS protocols. Make sure you are including ongoing review and observation to ensure staff knowledge and implementation of policies and procedures. And remember that the focus is primarily on patient care with these with the common condition level deficiencies. So a strong concurrent record review process, staff education, and survey supervisory visits are key. Again, documentation and audit compliance and survey readiness and quality should be an ongoing agency-wide effort. And this is not just this is not my reminder to breathe. It's for all of you to now take a breath. This is a lot of information. A lot is happening in our industry and space, and making sure that we step through it, that you understand what the priorities are, that you need to make sure that you are following to demonstrate compliance with regulatory and payment requirements and the changes that CMS is putting forth, and make sure that you are, again, advocating for yourselves that and to demonstrate that you are providing that highest quality care.
Remember,
Jennifer?
guys, compliance is not an event. It's an ongoing process.
Absolutely. And just finally, I don't know that we won't have time for questions, but we can certainly follow up with them after. We hope that you have enjoyed this session. I know it's been a lot of information, but it's timely and relevant information. Also, just as a mini announcement, Jennifer and I will be co-hosting the CHAP casts, our podcasts in 2025. Our very first podcast for this year will be on Special Focus Program, and will be published this month. So it might, and we did ask in the poll for any suggestions for podcast ideas. We're always looking for them, so we appreciate your input and your participation today. Jennifer?
No, I don't have anything to add. I just wanted to thank everybody for plugging in today. I know that your time is so crazy and you've got a lot of things to do. You have compliance to do, but thank you for plugging in to our webinar today. And hopefully you're taking a couple of pearls of wisdom around here or away from here. And we're here if you have any questions. We're here to support you. Thank you so much.
Thank you, everyone.
Denise, do you have anything?
I want to award a prize to both of you for your ability to get through all that material in exactly 1 hour's time. Well done. Thanks to everyone who attended today. We had a number of attendants and a great interest in this topic, so definitely appreciate you spending your time with us. Links to the slides have been shared in both the Q&A and in the chat. You can download them. The copy of this presentation, a video version, will get emailed. A notification will get emailed to anyone who is registered. So you will be able to re-watch the presentation if you would like. Lastly, I also shared a link to a survey. It is with regards to a specific workshop we're working to develop. And for any of you that are willing to participate in that survey, that really helps us a lot. And I'll say thank you in advance for those of you that take advantage of that. Otherwise, thanks, everyone. Have a great rest of your day.
Thank you. Bye.
Thank you.